Philippe Genereux. I'm an interventional cardiologist. I work at Morristown Medical Center, a kind of healthcare system in New Jersey. Likely 4 years ago, where the founder actually called me saying that he had a great idea and he wanted to have my input. And he first asked me if bleeding complications were frequent in my field, interventional cardiology, with TAVR and Impella placement, large bore catheter, and complex intervention. And obviously, these complications occur despite all the good will and good techniques. So he showed me a little bit the idea, and we start to discuss how to use this brand new device. And I was really intrigued and really interested to use it in complex patients. High-risk patient for bleeding, and this is a broad category that goes from obese patient or frail patient, patient with suboptimal anatomy for large bore placement, either Impella, mechanical support, ECMO, or also TAVR. So for me, I use it routinely, and it's the default venous sheath for Impella placement for all the patients with Impella placement, either in shock or elective PCI. And also the default venous sheath for pacemaker placement for TAVR at high risk, frail patient, obese, tight vessel, or when we use shockwave, when we push the limit. So these are the top of the list patients where I like to use it. Good thing about the early bird is there's no disruption at all of the workflow. As a matter of fact, is a standard endovascular sheet, 6 French or 8 French. So it's very easy to integrate in our practice. When I do TAVR, for example, or when I do Impella placement PCI, I use the early bird as a sheet to either deliver swan guns, deliver a pacemaker, and it's really, there's no disruption really of my workflow. So the early bird was well received by the supporting staff, either the nurse practitioner, the physician assistant, and any healthcare worker at the bedside of the patient, caring about the patient. And a lot of nurses told me that they see that as an extra pair of eyes to help them take care of a patient after recovery of a large bore catheter procedure or any endovascular procedure. So the early bird helped them really to decipher between, is this a bleed that occur or not, is why the blood pressure low, is the bleed or not. Really has been very helpful to help them in their practice to optimize the care of their patient. So really well received by our community at Morristown Medical Center, and really, as a matter of fact, an extra team player in the care of our patient. The early bird really enhanced and optimized my practice. One case that I remember vividly is a very challenging TAVR case, obese patient, old patient, with suboptimal vessel, very calcified and tortuous. We use the shockwave device, as a matter of fact, to get the TAVR sheet in. And we also use the early bird next to the TAVR sheet for delivering the pacemaker. And we activate the early bird, and during the cases, when we remove the large TAVR sheet after the completion of the TAVR, the early bird start to alarm us that there was one level of bleeding. Quickly, we went crossover and inject the contralateral artery, and actually, as a matter of fact, they were an external iliac perforation, most likely due to the suboptimal anatomy. And so quickly we brought a balloon and tamponed that the bleed, removed the TAVR sheet, did it perclose, and actually finished with a cover stent. So this case actually was a near catastrophic bleed that the early bird captured right away. As a matter of fact, was the first commercial use of the early bird in the United States, and that was a very vivid example of the use of early bird to detect bleeding just at its beginning. And we could have waited longer, and the bleed will have been obvious and patient hypotensive, but the early bird detect right away during the case the initiation of a bleed that we could treat very successfully with no complication for the patient who went on 2 days after his TAVR.